I am Paige Nuez, Director of Family Empowerment at the International Rett Syndrome Foundation. And our board of directors and all of us at IRSF want to thank you for being with us today to level up your skills in identifying and caring for our male loved ones with Rett syndrome. Beyond today's webinar, we also want to thank everyone for your IRSF support and engagement, because continuous awareness and fundraising is critical to our shared success. And in fact, the very research being presented today was supported by IRSF through our own donor-directed Barrett Otis Research Fund, which was established in 2023 to enhance understanding and develop treatments for males with Rett syndrome. And this is a direct outcome of that donor-directed fund. So we really greatly appreciate the impetus for this, the Otis family. Contributions to this fund support studies aimed at improving the lives of affected boys and men, and we're happy to have this study's investigators and authors with us today to present their groundbreaking learnings. And I say this both as a parent to a beautiful young adult with Rett syndrome and as your IRSF advocate. We wish everyone to be as educated and empowered as possible as you care for your child, and as you speak to others about your child or work on behalf of your Rett programs, patients, studies, students, or clients with Rett. We welcome you and thank all families, caregivers, clinicians, research, and industry for joining us today with Dr. Talia Thompson and Dr. Tim Benke. So Talia Thompson is an assistant professor of pediatrics at the University of Colorado School of Medicine and a licensed psychologist with Children's Hospital Colorado. She's also a clinical and translational research scientist with a focus on psychosocial development and quality of life in rare pediatric genetic conditions. She uses community engagement, qualitative, and strength-based methods to produce meaningful research grounded in the priorities of the communities she serves. And Tim Benke is a professor of pediatrics, pharmacology, and neurology at the University of Colorado School of Medicine. He is a pediatric neurologist, research director of the Neurosciences Institute, and medical director of the Rett Clinic at Children's Hospital of Colorado, where they see all people of all ages with MECP2, CDKL5, and FOXG1 related disorders. He participates in clinical trials, clinical research, and translational research to improve the lives of people with these disorders. We've invited you to this RettEd session for understanding the male Rett spectrum and unique challenges that families face in receiving an accurate diagnosis. During this webinar, Drs. Talia Thompson and Tim Benke will share findings from their recently completed IRSF-funded study exploring the diagnostic journeys of males with MECP2 loss of function variants. And you'll hear about the medical biases and diagnostic delays that contribute to underdiagnosis and learn why more informed, targeted clinical care is urgently needed. Thank you for submitting your questions in advance. We received them and forwarded them to our presenters, who have integrated responses to your questions into their slides. So listen for your question to be answered in the duration of their presentation. You can also submit additional questions that come up throughout the presentation in the QA form, and we'll address those during our QA at the end of the presentation if we have time. So with that, I now invite Dr. Thompson and Benke to take the virtual stage and help us better understand your new learnings. And Dr. Thompson, your screen sharing. Thank you so much. All right. Oh, we'll wait for your slides to come up. They're coming. There we go. And if you come off mute, you guys are ready to take over, and we'll see you at the end of your presentation.
Thanks so much. And thank you for the warm welcome. And I think Dr. Benke is going to start us off. Dr. Benke, can you see the slides okay?
Yes.
Right.
And can you hear me okay?
Yeah, sounds great.
After that little hiccup getting on. Right. Thanks, everybody, for being here today. And if you go ahead and to the next slide. So this is our team. And a lot of this team was at the IRSF meeting in Nashville several years ago. Some of you will remember that. And that's really what, in a lot of ways, kicked off this project. We'd already been studying males with Rett syndrome as part of the natural history study funded by the NIH. And that was, of course, led by Alan Percy and Jeff Newell. And at the IRSF meeting, there was a group of families there, and we heard what you guys were going through. And that's what kicked a lot of this off that we're going to talk to you about today. But here's the team. we couldn't have done it without everybody. Everybody contributed something that was hugely important to putting this project together and going forward. And I think those of you that participated will, of course, recognize Talia and Dennis, because those were some of the folks that you spoke to during the meaty work of this project. So next slide, please. So a word about pictures and quotes. And a lot of what we found with this project was just the words that we use are so very important to everybody. And we struggled a lot with making the words useful and effective. And so we've tried to be careful with how we approach this. But what it comes down to is we ended up calling this a Male Rett Spectrum. And we've got a lot of pictures of from the families who've all agreed for us to share them, and the quotes as well. So next slide, please. So Rett syndrome in males. So there's a lot of common misconceptions. They continue to be propagated. Even at the last science meeting, people continue to use things that were out of context and out of date. And those misconceptions include that males with loss of function, that's what LOF stands for, loss of function MECP2 genetic variants, do not survive gestation. People continue to refer to this only as early onset severe encephalopathy and death in infancy, which we know is not true, because you can see the pictures here. So what we found there were a lot of recent studies that were showing a wide variability, and this led to a proposed third type of Rett syndrome. And again, even that term was quite broad, and it was male Rett encephalopathy. And this was what came out of studies from the natural history study that we published in 2019. Next slide. So this led to this project, as I mentioned, that was really kicked off at that Nashville meeting, that we wanted to describe the diagnostic experiences, clinical features, and daily life of people with male Rett syndrome. And this was funded by International Rett Syndrome Foundation, as Paige was describing, but also through Rocky Mountain Rett Association. So we used surveys, interviews, and an international sample. These were males of all ages, alive and past, and they had the entry point was a presumed or pathogenically presumed loss of function alteration of MECP2. Next slide. So who participated? It was 48 families that were enrolled between April of 2023 and October of 2024. And there were 32 families that were interviewed in depth. And these families included family members that had 37 living individuals with male Rett syndrome, aged 6 months to 31 years of age, median age being 8 years of age, and families that had 11 individuals who'd passed with male Rett spectrum. The age of death ranged from 1 to 16 years of age, and the median age at death was 6 years. Next slide. So this is really important about Rett syndrome diagnostic criteria. And it's important to note that this is a diagnostic criteria, and it is a clinical diagnosis. It's not a genetic diagnosis. And so after a lot of consensus, there was a paper where Jeff Newell was the lead author in 2010, where people came to a consensus about what the diagnostic criteria were for Rett syndrome. And it was clear from that paper that it was a clinical diagnosis. It might be informed, but not necessarily include the genetic diagnosis. And that clinical diagnosis includes partial or complete loss of acquired hand skills, partial or complete loss of spoken language, gait abnormalities, which can be delayed, but they then are found to be impaired, or there's an absence of ability. And then there's stereotypic hand movements that come in a variety of different descriptions, such as hand wringing being the most typical. And so through the surveys that we went through, we found that 48%, that is 23 males, met 4 out of the 4 diagnostic criteria for classic Rett syndrome. And 92%, or 44 boys, met at least 2 out of the 4, which would be the prerequisite for having a diagnosis for atypical Rett syndrome. And so this is all part of this issue of that the clinical diagnosis versus the genetic diagnosis really underlies the spectrum. So in other words, if you have a loss of function variant of MECP2, you can be anywhere along a spectrum of people that either meet criteria for typical Rett syndrome, atypical Rett syndrome, or even those that are outside of that don't meet criteria for atypical Rett syndrome, but you still have challenges. Again, it's important to note that this is per the parent report that we used through surveys, because often what we found is that it's when we see you, say, in the clinic, we go over these questions in depth and examine really what you meant by the different answers to tease out really whether or not you meet the criteria. Next slide, please. So with regards to communication development, that 40% at any one point obtained communication with sound or spoken language, 57% effectively and consistently communicated non-verbally, and 72% were felt to understand language. 57% had a regression in verbal communication, 43% in nonverbal communication, and 34% in receptive communication. And in all instances, the age of regression was around 22 to 24 months. Next slide. With regards to motor development, 60% had regression in hand use, where the median age at regression was 18 months. And 62% had a regression in gross motor skills, and that mean age at regression was 24 months. And it's important to compare this through females. Females also have a regression in gross motor skills, but it's much slower and insidious compared to what we were really finding with people on the male Rett spectrum. So, and this is just a note here at the bottom that functional hand use was described as holding a cup or bottle to drink, hold utensils, or fed themselves. Next slide, please. So there were a lot of other clinical characteristics that we collected, and there were a lot of people that had all of these different features here, such as abnormal tone, breath holding, teeth grinding, which is what bruxism is. Cardiovascular concerns was relatively less. Dysautonomia, this is things like abnormal skin temperature or color. And then hand stereotypies. And I put the star next to hand stereotypies as being at 70%, because this is a feature that usually puts you into either a typical or an atypical category for Rett syndrome. Next slide, please. Other clinical characteristics, a lot of people had G-tubes. There was reduced response to pain. Scoliosis is a frequent feature. And again, this number here is somewhat similar to what's seen for females with Rett syndrome. Screaming spells, seizures, sleeping difficulties, all very common. And overall, seizures are really somewhat similar to what we see with people with Rett syndrome across males and females. Next slide, please. So we asked everybody, because this is something that is really important when you think about clinical trials, is you want to address, when you set up a clinical trial, you meaning industry or investigators, you need to address what's important to families. And you told us when we asked you, what are your top 5 concerns? Seizures, breathing abnormalities, and lack of effective communication were all at the top. We didn't have enough people to say that one was necessarily more than the other for these top 3, but they're all pretty similar with regards to how often people were saying, these are what's important to us. And then other things that are still important to people. So in other words, if you said in the top 5, you're likely going to be represented here. So that includes things like constipation, abnormal walking, problems with sleep, frequent infections, breathing abnormalities, which include carbon dioxide retention, intellectual disabilities, and dystonia. Next slide. So in terms of, we also wanted to assess quality of life, because this is something that could be used as an outcome measure in a clinical trial. And what we found is that through the survey instrument that we were using, that there were similar quality of life scores between males and females with Rett syndrome. And interestingly, there was a big overlap with CDKL5 deficiency disorder. But all in all, there was a wide range of what we found in terms of quality of life. And that is partly due to the fact that this was relatively a small sample for what we were doing. But also it demonstrates that there's a big range of what people are experiencing in terms of quality of life. Next slide. So in summary of the clinical characteristics, there's a wide spectrum of outcomes, and that many have symptoms and quality of life that's similar to females with Rett. But importantly, some males have more severe medical needs. But many reach early milestones such as walking or babbling. Regression often happens before age of 2, and about half meet the criteria for classic Rett syndrome. And so those, we think, are very important characteristics that's never really been addressed before in a sample like this. And so we think that that's an important thing going forward. So I think do I have the next slide, or are we switching over to you? Yes, we're switching over to you, Talia, to talk about everyday life for families.
Yeah. So in addition to collecting our more standardized data through surveys and some more standardized quality of life measures, we also felt like it was just essential that we talk and hear directly from families. Sometimes when we use surveys, especially in really rare conditions, we miss really important topics that families want us to be investigating, just because we don't know enough to even ask the right question or use the right measures. And so that's the reason why I was brought on to be a part of this story. Something that I do a lot of is our qualitative research methods, where we interview families and try to learn what are the most important themes and what do we need to focus on as a research community. So we spoke with 32 families. Interviews lasted around 90 minutes. They were very in-depth, and we want to thank all of the families who participated in those interviews. I know the surveys are long, and the interviews are also really long. And we appreciate you taking the time in your busy schedule. We hope that we can really highlight your voices by sharing what you shared with us out to the broader community. So families shared with us what they want the Rett community to know, what they want medical professionals to know, researchers to understand. And then from these conversations, we identified key themes that really we found across the world that seemed to be strands or threads that were common across families, even in very different contexts, different countries, different healthcare systems. So one of the most important things we learned from families of boys on the Rett spectrum is that there is just tremendous variability in their experiences. There's not one story about life with male Rett or on the male Rett spectrum. Each child, every family has a really unique journey. It's interesting that the literature has so often put forth that it's a uniformly very severe condition, because actually there's a full range of abilities and challenges that we observe in this condition. So in our group, some boys required comprehensive around-the-clock care. This is a parent here, a quote from a parent who shared that their son is completely dependent on them for all aspects of daily life, requiring what we call total care. So there were several families who described needing to support their sons with feeding, mobility, toileting, communication, and especially as boys grew older and experienced regression and needed more help and care and support with the loss of skills. But at the same time, the other boys showed much more independence. So there was a subset of boys whose families described them as only having mild delays. This was a parent who told us their son is actually able to ride a bike, to build, to run, participate in activities in the community. Both of these boys have a loss of function MECP2 variation and would fall on what we're referring to in this presentation as the male Rett spectrum. And what we heard from families is that this wide range of experiences is just not always recognized at the time of the diagnosis from healthcare providers. And that can make the diagnosis much more distressing to not know the full picture. It can lead to misunderstandings about what's possible for a boy who's receiving this diagnosis. And it can create barriers to families feeling a sense of belonging and feeling like they can really that they really have a place in the Rett community if they are higher or lower functioning or have more or less needs. So we heard stories of people questioning, does he really have Rett, which can be really harmful for families that are already under stress. And so we as a team just want to encourage a more inclusive understanding of males on the Rett spectrum and know that there are many possible outcomes. And at this point, we only know as many stories as we've heard, but we feel like we'll continue to hear new stories like this. Across all these developmental levels, across this whole spectrum, though, one common theme is that families of boys with Rett syndrome often describe their caregiving as an all-encompassing experience. So for families with boys with complex medical needs, home life could look and feel like a hospital setting at times. One parent of an 8-year-old shared with us the ventilator, the suction machines, the oxygen. It's like we have a mini ICU here in our home. But even families where boys had fewer medical challenges, the caregiving burden remained really high. There was a constant need for vigilance, monitoring their sons closely for any signs of regression, for seizures, and just to ensure their child's safety at all times. It's really 24/7 caregiving. And then here's a quote. The parents also shared the just deep exhaustion, physical, emotional, that comes for caring for a boy with Rett syndrome. The condition really touches all aspects of life. It doesn't turn off at night. This was a parent of a 20-year-old describing her caregiving needs throughout the night when her son was younger years ago. She told us, my brain was always on, even throughout the night, whether he was yelling or not, I would hear him. His room was pretty far away, but I would wake up. I always heard him. That was a lot. And we just think these stories really underscore this urgent need for family-centered supports. And families caring for boys with Rett, regardless of where they are on the spectrum of male Rett, they all need resources. They require respite care, and they need connection to each other and to the broader community to sustain these roles and their well-being. You know, research has shown in other conditions that caregiver well-being directly impacts the health and the well-being of children in their care. So we heard this as a calling for us as a community to provide family level supports for boys with Rett. And so based on these results, our team is currently actually working on a project funded by currently by the Rocky Mountain Rett Association with some more grants under review. And we want to develop a caregiver intervention to support families with these intense responsibilities. Another common theme that emerged in our interviews was the sense of isolation felt by families. I'll say that this adorable picture of this boy, he's clearly not feeling isolated. And we heard a lot of stories of families, like circling the wagons was a term we heard, where families became very, very close and came together to support their sons. But we also heard consistently across a lot of families that over time, friends and extended family became more distant. It became harder to coordinate visits or stay connected. Families just had to prioritize their son's healthcare needs and really couldn't always participate fully. And often parents had to, one parent would leave a job to stay home and provide care, which was often the mother, not always, which could be an isolating event. So one parent of a 5-year-old whose family had really stopped inviting them to events, friends had withdrawn, put it simply, she said, no one really reaches out to help us, so it's just us. And we know Rett is already a really rare condition, but it's even less common in boys. So many parents felt like their son was the only one in the world with this diagnosis. That's a very isolating feeling. And actually, for some of our participants, you know, we had participants from across 6 continents. So we heard from people all around the world. And for some people, their son was the only male with Rett syndrome in their country, in the entire country. And so for some, it just took a long time to find others who had similar experiences to them. One parent shared that it probably took 5 years before I found the Boys with Rett group and learned I wasn't alone in the world. It's also important that we say families also described even feeling isolated within the Rett syndrome community at times. So having resources or educational materials or Rett syndrome events that used language that only referenced girls. And so that's one of the key reasons why IRSF funded this work, really, so that we can build a more inclusive understanding of who has Rett syndrome and who belongs in this community and help lead to a feeling of belonging. There's a thunderstorm going outside of my house right now. So if you can hear that, I apologize.
Mine too.
Yeah, well, we're neighbors. Families also shared that there was a serious lack of awareness and persistent misconceptions around male Rett syndrome in the medical community, which meant that families had to advocate fiercely for their son's health and well-being. So parents shared a lot of stories about fighting with insurance companies to approve medications and therapies. Some insurance companies would tell parents, males don't get Rett, so your son can't have that, so we cannot approve that drug, which is just devastating as new medications were coming out and becoming available to females. Parents were constantly teaching their sons' medical providers about Rett-specific healthcare needs, specific medical protocols like sedation protocols that providers didn't seem to understand would also apply to males. And at times, the advocacy really felt like a battle. Parents described it as a fight sometimes. One mother shared, "It's a battle in itself to parent a child with Rett. It seems so unfair. You also have to battle the specialists, doctors who just don't want to listen." And another parent told us, "That's basically all I did when he was alive, fight for what he needed." But despite all of these challenges, their medical developmental challenges, the isolation and advocacy needs, we cannot emphasize enough how often we heard from families about how deeply loved and cherished their sons were, and how important they were as members of the household. So parents spoke about their sons' unique personalities, their preferences for certain songs and television shows, their favorite books, their favorite family members who just lit up their eyes when they came in the room, love for cuddling and being together. We heard so many stories about these cherished boys. One parent told us he loves school, he loves going on the bus, he loves getting out and about, meeting people. He's nonverbal, but he's very social and likes to be included in everything. We're pretty lucky, I said. Another parent who was reflecting on her son who had passed away at age 12 told us he was a very positive kid. He was always smiling. He had a good sense of humor. He loved being around family. He loved being around water. He was a fighter. We think these stories are really, really important to share. They really challenge those stereotypes, the harmful stereotypes that suggest Rett syndrome in boys is incompatible with a meaningful life. We heard so many stories of beautiful and meaningful lives that we really want to recognize and encourage support for. So putting it all together, well, we heard about living with boys with Rett syndrome. Boys are loved, they bring joy to their families, but at the same time, caregiving can be incredibly demanding, and many families do experience isolation. And despite these challenges, families are strong advocates. They're working really hard to get their sons the care and respect and opportunities that they deserve. One of the important things that this study wanted to look at were diagnostic experiences, and that's part of our study. It's a little separate from their lived experience. We wanted to know, how do people arrive at this diagnosis with males? And so we have a new paper out. It's been published in the American Journal of Medical Genetics, and you can use this QR code to link to the paper. We've made it available, and if you're unable to use the QR code, we have other ways to get that to you. I can try to put it in the chat later as well. Sometimes those don't work. But what we heard from families about how kids receive this diagnosis is that it's a diagnostic journey, and it often happens across 3 phases. So I'll just sort of go through each phase because each one has points where we could do better. We could improve the experience for families and for these boys. The first phase is that families described many different and difficult paths to getting the correct diagnosis. So it's important to note, well, girls often are diagnosed based on those clinical symptoms that Dr. Benke talked about earlier. Sometimes they're even diagnosed by a general pediatrician. That happens. Boys are exclusively, or the boys in our study were exclusively diagnosed through genetic testing. So even if their clinical symptoms do align with the criteria for Rett syndrome, the diagnosis was triggered by a positive genetic test that indicated it could be Rett syndrome. So for many, these were very long diagnostic journeys. It took a long time for families to get the accurate diagnosis. But for some, in our younger participants, the diagnosis was identified quite suddenly, often after a serious medical event, like a seizure or a cardiac event, a breathing problem. So in these cases, doctors were ordering a whole exome panel while a child was admitted to the hospital, and the MECP2 variant was found really unexpectedly. Before more classic Rett syndrome symptoms appeared, like things like developmental regression, so it was often quite surprising to providers. When we looked at the data, we found on average, boys are diagnosed with the MECP2 variation around age 3, but it can be anywhere from 3 months, very young infancy, up to 16 years. On average, families had to wait about 2 years through testing and different diagnostic processes before they received the accurate diagnosis. But again, there was a broad spectrum. Some had to wait over a decade, with multiple times retesting different tissue samples and waiting for genetic technology to improve before they could get that correct diagnosis. Most boys received other diagnoses first, and these are the most common that seem to come before the Rett syndrome or MECP2 variation. And the good thing is that we are seeing a positive trend in the data. The age of diagnosis is decreasing each year as genetic testing becomes more routine. So after families go through this long journey and they finally get this diagnosis, they have a conversation with a diagnostic provider. And families described those conversations to us. They told us when they finally received the diagnosis, the conversation was almost always delivered by a provider with very little knowledge, sometimes no knowledge at all about male Rett syndrome, which families found distressing. Families did not expect to, or nor did they want to be the expert on their child's diagnosis. Often providers were sharing outdated or inaccurate information. Parents were told frequently, don't Google it, which of course families disregarded, and they all went and searched it. Naturally, they wanted to know more, but sometimes information online that they found was misleading or inaccurate as well. We think it's important to note that most boys were diagnosed by highly trained specialists. These are geneticists and neurologists with a lot of training. But most providers were just simply unaware that Rett syndrome could even occur in a male, or they were in disbelief. Some parents were told that it's a mistake, that couldn't possibly be an accurate result. Even doctors who were Rett experts sometimes hesitated. It's just, we've all learned, I know in my own training, I was taught that Rett syndrome only happens in girls. And so providers were telling families what they knew, what they had learned. But one parent shared their provider had told him, if you had brought him in with a wig and a skirt, I would have diagnosed him today. This is a classic case of Rett, but he's a boy, so we got to do more testing. So after this conversation, families had a wide range of emotional responses to receiving this diagnosis. Many experienced intense feelings of grief and despair. Others had a sense of relief at finally having answers. Most had all of these emotions and many in between. So in our survey, we asked parents to rate the diagnostic experience. What was it like to receive this diagnosis? From mostly negative here in the red zone, to neutral or mixed response here in the middle in yellow, or a positive experience here in blue. And we were surprised. We had a real mix of responses. Almost half described the experience as quite negative, which is not surprising. But the other half reported more neutral or even positive experiences. And interestingly, the parents we interviewed of older sons who had received the diagnosis much later in life, the young men in our study, they'd been searching for a diagnosis for over 10 years. And so for them, they just often felt relief at having an answer. And they were able to ignore some of the misinformation or more harmful information being presented because it just didn't match their own reality. It didn't feel relevant. But for the most part, most families did experience some extreme anticipatory grief. Many families described it as feeling like a death had occurred. These reactions were really intense when the diagnosis was delivered by an insensitive provider or someone who seemed quite confused. But for some, even though it was painful, it brought new direction, it brought hope, it brought access to interventions. Some became eligible for more respite services. And I think most importantly, many families found comfort in the connections that they got. So this family told us, Rhett's a terrible diagnosis to get, but the silver lining was that this is how it has to be. At least Rett has a really big community of people. So while we know the diagnostic experience is very challenging, sometimes it's what leads parents and families to this community, to the Rett community, where they can find resources. And that's how we want to end with you all today, is to talk about what can we do as a community. And Dr. Benke is going to share some strategies, right?
Okay, thanks. And oh, by the way, I am seeing the questions that some folks have posted, and we will, if we don't get to them with the slides, and I don't think we have with some of those that are posted so far, we will get to you. Okay, so how can we all support the community? And so the first one is use inclusive language. And I think for all of us who were trained in a certain way, and this is what we learned for so long, it takes some of us a while. And even, I realized, oh, did you just hear what you just said? And so we all have to do that. But I think, what we've talked about a lot amongst ourselves is what's the best way to do this. And so Male Rett Spectrum seems the best way of doing it. But we want to make sure that we're using inclusive language, that we're all part of this, and as we go forward. So next slide. So how can we improve diagnostic experiences? And this is one of the purpose of the papers that we're publishing, is we want people to be aware in the diagnostic community of their actions and their saying and how they do things. And one of the things that I think that it's important for people to do is return visits to your diagnostic team are important even after the diagnosis. And this is because even though you have a diagnosis, this is a rare condition, and we continue to learn more about it as with every day. And so going back to your diagnostic team, if you're not with a center of excellence or anywhere else, it's important to go back and revisit and say, what's new about what I have? I already have a diagnosis from you guys, but what's new? So we want them to be able to share current and accurate information. And one of those important pieces is that the Rett syndrome comprehensive care guidelines do work for people with Rett syndrome across the male and female spectrums. And that's an important piece. It's like here's a list of things that will get you going if you think that you're coming up at a loss about what to do. We want to connect families through these centers of excellence. We want to figure out how to offer them respite and in-home care and nursing and other interventions to improve their quality of life. And then also just to make sure that they know that there is a Rett syndrome community out there. So how can males receive high quality of care? And so this is through the International Rett Syndrome Foundation Center of Excellence Network, where males and females of all ages are there. And it's important that we think that families find comfort where we can say, we've seen this before. Now, I have to say that none of us are experts in any of this, because as soon as you walk out of the room, you realize, well, I haven't seen that before. But that's the whole point of going to a Rett Syndrome of Excellence, is because at that center, they're going to continue to see new people and build upon their own experiences. When we started our clinic over 10 years ago, I was then, and I still continue to feel a bit like a fraud, because I'm continuing to learn, and you all are teaching me more as we go forward. But basically, we're not here to take the place of your home team. We're here to complement them. And this is through diagnosis, prognosis, management, and clinical trials information as well. And it's important to note that even if you can't go to a center of excellence, this is a team sport. We want your providers to reach out to us. We're here as a resource for them if you can't come to see us. That's what's important to note. It's a team sport, so we're here for you. Next slide. So how can males and their families participate in research? Well, there is the Rett Syndrome Registry, which is open to everybody who goes to one of the centers of excellence. We have another study that's going to come out soon called Caregiver Speaks. It's going to be males and females across the spectrum. There is the Lotus study, which is a phase 4 study to follow all people with Rett syndrome who are being clinically treated with Daybue or trofinetide. So if you are a male or a female, you agreed to enter the Lotus phase 4 study. It's important to note that there are important resources that you can continue to keep up with. That's one of the purposes of being seen at a center of excellence. For instance, our center, we see you every 1 to 2 years, but it's your place to learn what's new, and that includes clinical trials. But the other sources for you are clinicaltrials.gov and the Find a Clinical Trial feature that's on the rettsyndrome.org website. Next slide. So this was one of the most common questions that showed up beforehand for folks. And one of the first we think that what we're doing is one of the first steps, is we want to define and inform the scientific community about the disease. And because we want industry who are sponsoring a lot of these clinical trials, is that there is a such thing as a male Rett spectrum that they should be thinking about when they're thinking about defining and setting up clinical trials. And so I think that the first next steps is that there's going to be inclusion in non-gene therapy interventional trials. And industry is now talking about it. After years of poking and prodding, they're now starting to talk about it. The next thing that comes up a lot and came up a lot in the questions was gene therapy trials. And the question is when are males going to be in these trials? And it's important to note that this isn't up to us. It's up to the companies. They make those decisions. We poke and prod as much as we can and say, well, what about this? What about that? But in my opinion, companies are seeing a significant risk benefit in the path of getting FDA approvals for gene therapy due to the clinical spectrum of male Rett syndrome. They want very homogeneous populations that they can study such that they can be confident, and the FDA can be confident that when they present their results at the end of the trial, that this is really a thing. So, and they're making their inclusion criteria in these trials based on a clinical and a genetic diagnosis. So the questions that they're forced to address are, because of the spectrum of clinical features and natural histories across the Rett spectrum that includes males, is will the same outcome measures work when you study this diverse population? One of the questions that also comes up are immune issues in gene replacement therapy. So in the case of certain males, their bodies would not have ever seen MECP2. And so is there going to be an immune response? It doesn't appear to be the case in terms of the animal studies that have happened so far, but it is something that people think about. One of the big questions is if we do get approval in females with classic Rett syndrome, will post-approval this be open to males across the spectrum? We don't know the answer to that, but we do know that, I mean, the question is because in debut, trofinetide, when it was approved, the label says Rett syndrome. And so it says nothing about males. And so therefore, males are now able to have access to trofinetide. Is that debut experience going to be the same in Translate? We don't know. One of the big questions is when will we see approval in females with classic Rett syndrome? We don't know the answer to that. I think it really all depends on the current trials and how things go with those trials. And they're very small trials. They're very expensive to do. And so we don't know how they're going to turn out and how that's going to proceed for when the companies then approach the FDA. Here's our data. Is this good enough for approval? And we don't know if the FDA is then going to say when they give that approval, how specific it's going to be. And if it's overly specific, is that then going to require additional trials to be required for FDA approval in males? So there's a lot of unknowns here that we don't know, but they're out there. And so while I very much want to answer your questions, we don't have, we can't at right now. So, all right, next slide. So that's the end of what we have to show you. And so we're very thankful to International Rett Syndrome Foundation and Rocky Mountain Rett Association for funding the trial, but also special thanks to the families who shared their stories, which was just a lot of work and really helped shape the project. We started with families. Families informed the project as we got started and moved along, and we couldn't have done this without you. And I hope that you think that it's successful and it's going to serve as a springboard to go further forward. So with that, thanks very much. Paige, I think what I'll do is I'll just start with the online questions and I'll just try to answer them live and then click them as opposed to trying to type something in that I'll have a bunch of typos. Is that okay, Paige? I do
That's
that?
the best way to go about this. Thank you so
Okay.
much.
So the first question there is, my son is 36 and was just diagnosed with Rett syndrome 3 weeks ago. Up until the age of 30, he was the highest function of special needs adults. And in Pennsylvania Special Olympics, he was the bench press champion, benching 125 pounds with a body weight of 130. That's just amazing. I love that. Since then, his health is starting to deteriorate. Thoughts? Well, I think that that's the differential diagnosis of deterioration, and what you mean by that is really very broad. And I think that what's important is if possible, if he can be seen at one of the centers of excellence. There's a really good one there in Philadelphia at Children's Hospital of Philadelphia. If you can get there to be seen by the center there, or you can have your clinicians get in touch with any of us at the centers of excellence to talk about what's going on with your son. We're here to help with that. But I think that being seen and somebody actually, doing an exam and asking you all of those questions about trying to get to the bottom of this is very important. Because I don't think that I could say, oh yeah, I think that this is part of his Rett syndrome. I can't say that. I think that the full picture about what's going on really needs to be explored. I hope that comes close to helping. The next question is, hi, do you have any idea how many males there are around the world who have male Rett spectrum? Uh, we did our best to cast a wide a net as possible to get as many folks as we possibly could. And we have Kate Ferdinandson to thank, who was instrumental in, through her um, uh, closed Facebook group, to try to recruit as many people as we could. We'd very much like to, if we have the time, space, and money to go forward with continuing to collect folks. But this is the point of the Rett Syndrome Registry, is to continue to collect folks into that registry of people with the male Rett spectrum. So I'm a mother of a son and a carrier without symptoms. So and you say, go on to say, I've not heard of other families with this situation. So we've seen this. So this is something, it's in the paper that we published, that this is not uncommon. It's also in the 2019 paper, that this is something that we've seen before. So it's not common. We can't give you a number about people with male Rett spectrum in the world. And I think we're still suffering a lot due to underdiagnosis. I think that because there's greater access to genetic testing, I think more people will be diagnosed, and hopefully with the papers that we're publishing, people will then search and say, oh, well, I guess this is a thing, and be more comfortable in making the diagnosis. I think also in regard to the first question is that there is a shift in the diagnostic approach of clinicians, whereas in the old days, and I still qualify for people in the old days, is that we would see you in clinic and say, oh, here are your symptoms, I will order this test. Whereas the new generation is I see that you're having a problem, I'm not going to be specific about what I think this is, I'm just going to order this blanket test, which is the exome, that then comes back, and then there is a bigger discussion. Also, I would say that that a lot of, once you move in that transition from pediatric to adult medicine, the access to genetic testing falls off because adults aren't comfortable with doing genetic testing and making these diagnoses. And so what we're seeing is in older folks like your son who's in his 30s, is we're now seeing that the providers that are adult providers are more comfortable with genetic testing because it was part of their training, and they're sending it off. And also families are transitioning to younger caregivers as opposed to the older parents. And those younger caregivers are asking, I want more answers. And so it's just a different mindset on both in terms of the families and the clinicians that we're getting these diagnoses. Can you talk about Verinostat? No, I think that's a bigger question, and I'm not sure what to say about Verinostat. Beyond what it's out there as something translationally that's suggested, but there isn't any data that we have to present, nor do we have any access to clinical trials where it could be used. Let's see. I understand that males with Rett as a spectrum have concerns that families will then be more reactive than proactive because the message is this is a big range. For those children that are so significant and critical, early measures such as trach ventilation are being followed by cardiologists. It's so important to be ahead of it. But some males don't need that intense critical condition. Will families know based on where the mutation has occurred in MECP2 will provide some guidance with how critical their son will be? So that's one of the big questions that we've always had in across Rett syndrome males and females is, can we be predictive about if you have this change, you will be this severe? And I think that we might be able to do that more in males than we can in females because there's other features that affect severity. But we'll see, I think, as more time goes on and we see more males and discover what their clinical spectrum looks like through things like the Rett Syndrome Registry and this project here, we might be able to answer that more. I think my son is on the most favorable side of the spectrum. He's 6 years old, walks, talks, 5 words, walks and runs, moderate intellectual disability. I would like to know if it is probable that he suffers a regression in the future and what his expectation of life is. So we know from studying males and females for people who don't necessarily meet criteria for typical or atypical Rett syndrome is they may not ever have a regression. But I think that as we study this more, is we may understand that the regression can be more subtle. We know that in girls with typical Rett syndrome, that they have a slow decline in gross motor function. That's walking and sitting and things like that. Are we going to find this is true for people who just have intellectual disability? We don't know that, but I think that that's one of those things that we would all like to study and know more about so that we can answer your questions better than we just don't know yet. Our son is 7 months old and received a genetic diagnosis of the MECP2. He does not have any clinical symptoms so far. Are there any boys in the study who were genetically diagnosed before any clinical symptoms arose? And not in our study, but there are some that we are aware of that this is the case. And so it gets really difficult to be prognostic for families when you have just the genetic diagnosis, other than saying, this is where you are right now. And unfortunately, we don't know, but we want you to come back and we need to see you again to see how you're doing to address things as they come up. Thoughts about early genetic testing. My patient was diagnosed with additional testing done with the metabolic screen after birth. Are many institutions doing this? He is 6 months old already and monitoring symptoms for now. And yeah, there are some studies where there's the question about, should we put this on a newborn screen, if you will, to test for it? And I have feelings and thoughts which are my own about this. And I think that if you are to test somebody without symptoms, and this goes for families, if you are to test family members without symptoms, what does this mean? And I think that that's why it's really important that when you are pursuing genetic testing, that there is a genetic counselor that's part of the team that can say to families, let's talk about the test before we do it, because we want to talk about what are the potential answers that we can get from the test and to start to think about how we would process that information once we get it. And so it's one thing to think about it after you have it, but I think it's important to think about before you do the test about what you're going to do with that information. As future treatments develop, is there a way to galvanize Rett clinicians who are in contact with pharmaceutical companies to remind these companies that about our boys or young men with Rett? That's already happening. Trust me, I could be really annoying. So we're doing this. It's a constant thing that comes up. Oh, Talia wants to answer that question. Oh, no, okay. I think we just have to proceed. Thank you for the response. I think we just have to proceed with caution with adapting our name and language to male Rett spectrum. There is a time constraint to the boys with severe critical symptoms to their lives. Yes. There.
I think that one, the next one, Dr. Benke, is in a different language. So we had that submitted in the queue.
Okay.
We'll get an answer for this attendee.
Okay. My son has somatic mosaicism with a mutation on the start codon of the MECP2 gene. It is possible to have a prognosis with somatic mosaicism. So I think that that's a real challenge because we don't know what percentage of cells have the alteration. And when you get a readout of mosaicism, it's from blood or saliva. And the question is how reflective is the blood or the saliva as to what the mosaicism is in the brain? And they don't really match up. And I think that we don't necessarily want to do a brain biopsy to answer this question. And so we know that people with mosaicism can be, they're on that spectrum. And it's just important to continue to follow up with your clinicians to address needs as they appear. And then the last question is do gross motor skills continue to regress into adulthood? And what we know so far from females with Rett syndrome is yes, but that's because the tools have been applied to a larger group of people to this point, but it's something that we want to ask the question for males with Rett spectrum as well, but we don't have the data to answer that. I have suspicions that this is going to be the case, but I don't know the answer to that. I think it's just to follow with your clinical team to be on top of these things to, address, what are you seeing in terms of regression, and are there things that can be addressed from other therapeutic measures? What are the other potential causes? Is it necessarily a Rett, or is it something else that could be part of the regression? How are we
Okay.
doing, Paige?
We are right on time, and you got through the entire question queue. So you win a prize to be announced at a later date what that prize is. Thank you so very much, both of you. It is the top of the hour, so we are so grateful for everything that you shared today. We're grateful for the questions that were asked in the queue and the ones that were not repeatedly asked that were pre-submitted, because that means you did a great job answering them in your slides. But we know that this is a conversation that is going to continue, and there will be new learnings as new data emerges. And I really want to thank the families who did share their personal lives and their experiences and feelings and emotions. So much of it resonated with me as a parent of a female with Rett syndrome, and I am really glad to see the data aligning with the overall Rett experience more and more and more. This is the world that we want, is a world of inclusion where we're talking about Rett syndrome as just a spectrum disorder that affects people early on and well into adulthood. So thank you so much, and we really look forward to future learnings and future publications from you. So your dedication is impressive, and thank you for helping us fit the male Rett spectrum into our overall world of Rett syndrome, and keep up the great work. We appreciate you. You give us hope and determination and inspiration to do the necessary hard work that we do each and every day. And we want to thank you for your time today and wish you continued success in your efforts. Thanks for taking male Rett spectrum with such intensity, such sincerity, much empathy, and really with experience and your skilled knowledge, overlaying it with what we know. To our attendees, we hope you found value in today's session, and that the knowledge you learned today will empower you in ways great and small in your path forward. And as you go about the daily care of your child, we want you to take hope that the International Rett Syndrome Foundation is working diligently for better treatments and interventions for all impacted by Rett syndrome. And the days may be long, but we are all up to the task when we are empowered with factual guidance and information, and we remain committed to unearthing the mysteries of Rett syndrome. And my request to all, but especially to the families joining with us today, is that you continue to try your best to understand how to advocate for our mostly nonverbal children and to remain optimistic and replenished in your lives, because their success hinges on you. So please take the information learned today, access the resources that we shared, and apply all of this to all that you do in your daily lives and share it with others. Knowledge learned cannot benefit anyone if we don't actively share it. And this webinar is just one way that we can reach people around the world. 85% of our attendees today are within the US, and 15% are joining us from 11 countries around the world. So word is spreading, and we are grateful to be at the center of it all. So you guys just continue to believe in our special loved ones with Rett syndrome and be a part of all that is coming and all the places that we have to go together. Until we speak again, be well. Know that we welcome your feedback on what you need from our IRSF RettEd programming to best empower your efforts to raise your incredible loved one with Rett syndrome. And if you wish to see further research advances for our males with Rett syndrome, please consider supporting IRSF's donor-directed Barrett Otis Research Fund found on our website, rettsyndrome.org. And thank you both again so much. Thank you for all of our attendees. Thank you for everyone who contributed to this study, and congratulations on your publication. You are earth-changing. Thank you so much, and this concludes today's webinar. Take care.